What a great game. I always feel the EATs of the SNOT-22, we get much more unexciting severity scores. But that would be important.
But you mentioned an important point. Real-world evidence is not just big observational studies and registries. It's our own patients. This is real-world evidence. If you collect your own experience with treating patients with these drugs and the biologics, you gain your own experience and you see the outcomes.
And I just want to ask one more question, because you all of these dermatology have used for sure several systemic therapy, but you see the difference in the modification of type 2 among these systemic therapies.
Yeah, that's a great question. I mean, do you really have to specifically target type 2, or is just good disease control good enough? So for instance, if you gave a patient high immunosuppression with the JAK inhibitors, are you modifying the disease? And I think there is now evidence to show that you have to target type 2. Whether it's a class effect with all the type 2 biologics or it's specific to dupilumab is a question that we still can't answer. But certainly, I think broad-based, non-specific, non-targeted immunosuppression is not my favorite, especially for longer-term use to modify disease.
That's quite important, Mark. There's really accumulating evidence that, of course, you need disease control, but then it also depends on how you achieve disease control. For example, with JAK inhibitors, you can get nice clinical responses for AD, but we see no decline, for example, of IgE, other than with dupilumab. That is probably because they are so broadly acting and inhibiting also counter-regulatory pathways like type 1 and type 17. That's fine for AD by itself, but it's probably not so beneficial for the comorbidities.
How about the next question and your opinion as well, going to Professor Chang?
Well, it's very interesting that now we have one umbrella treatment that can cover all the type 2 inflammation. Probably also important for us to involve all the specialty like multidisciplinary approach when it see a patient with multiple comorbidities. And like what Prof. Sanjay has mentioned, our patient tends to drop out from certain disease that kind of go into remission. Yeah, so probably the physician who is dealing with the most severe problem will be the key driver of managing this patient.
I like the term umbrella treatment, I have to say. And what just came to my mind, the observation that the type of treatment is relevant is not so new, because we used a lot of cyclosporine in the past, at least for limited periods of time, and it works okay in many AD patients, but apparently it has no effect on asthma. And probably also because it's too broadly acting, affecting also pathways that are counter-regulatory to type 2. Right?
You said earlier about how TSLP failed in atopic dermatitis. That was a huge surprise to everyone.
Well, we have to say, failed is a hard word, right? There were some benefits in subpopulations of patients, but TSLP doesn't seem to be equally important across all patients with AD. It's different for asthma.
Asthma, it's great, very effective in asthma, and I think we can try and predict where drugs are going to work.
Is it like you prefer anti-TSLP maybe in asthma patients with no other atopic comorbidities, and then dupilumab in those with?
I think the first question is always the patient. So when I ask them, in fact, not even me, the nurse asked them, what is your preference scheduling? What is your priority symptom that you want to get on trial? Every biologic has a different pro and con. Arthropathies, arthritis joint symptoms is a side effect that we've noticed quite a lot more with dupilumab than the others. So people who already have painful joints, we tend not to refer to suggest dupilumab strongly. It's a balance of different things, and we don't. I keep telling my residents, don't chase perfect the first time. You don't have to. It's changed. If it didn't work the first time,
that's a big advantage as compared to oncology, for example. In oncology, your first shot should better hit, right? We have the privilege that we can still change if a therapy doesn't work.
Okay, so
Quick. It's better to be quick than right the first time.
let's quite get along with the next question that we're moving from the skin to the chest. Okay, so Sanjay, what the real world trial data do you find most compelling in supporting the earlier intervention with biologics or systemic therapy in high-risk patients?
So we finally in asthma published 25-year follow-up of people being treated with every kind of biologic, and that was in the Blue Journal this year. And there's a mortality reduction. So if you start biologics for any kind of, we've never shown that. There's never been a drug that shows mortality benefit for severe asthma, any kind of asthma. When we finally now have data that shows that if you start biologics for people with asthma who need it, you save lives. And everything else is periphery. You know, if you are reducing death, the conversation's done. You can't argue with that. And it took us a long time to get there because mortality is luckily relatively rare, and hopefully we won't have to wait as long to show in COPD, which I think we will start showing pretty soon. If it saves lives, that's enough. That's great.
Yeah, the thing is that in the real world data, you can see that we are looking into not, because most of patients we start very late and it has already developed remodeling and such. And what Dr. Stephen has been showing that early in AD, you can see, and I think most of us chest pulmonologists is now starting very early. And I can tell you, our colleagues in the Middle East with unlimited budget, access, they're starting very early, and they can see that they are actually reducing a lot of exacerbation, all the healthcare facilities and so on, and even mortality. So I suppose what Dr. Sivan showed very early, even to the start of infancy, is there a role of biologics at that time? And for us, early as step 4 or step 3, would that be a phenotyping at that age, and we could actually stop, and as our dream one day, like rheumatology, there will never be a severe asthma anymore. It's just that maybe uncontrolled asthma, but something that we need to actually bring forward all these things.
Okay. So I think Dr. Titiwan and also Asa as well are the best representative of our region. So do you think any barrier when you go into start biologics or systemic treatment as early intervention?
As early intervention. Oh, if only if only the pharma companies will actually bring down the price. I think we all are very comfortable to say, and I can assure you, I suppose when I speak to my colleagues in Thailand as well and Singapore, definitely they are very comfortable to start now. But the issue is the cost. But coming forward, and there might be biosimilars coming, and I suppose sad to say that is where we feel that we need that, because even in rheumatology, once the biosimilar came, it was like really in the first line, and now you see we don't see those hands anymore. So I think that's the way forward. And in honesty, what as experts is no longer when to start, but which to start. And how would you, like Professor was saying that we have the privilege to change, but if the need to change, then what to change to? So those are the things. Can we go to upstream or really focusing on the specifics downstream? And I was thinking about when you were saying about JAK1 and everything, I suppose in AD nowadays it doesn't really work. One few things that for us, if you have comorbidities, especially in our part of the world, TB would be a very high risk if you start those, but if you start in anti-IL-4, dupilumab, and it doesn't affect at all with the TB. So that is a bonus to this group of patients as well.
Well, how about you, Dr. Titiwan? Any barrier?
Yeah, okay. So, first of all, I'm Titiwan. I'm from Chulalongkorn University, just a few kilometers away. Thank you for having me. My background is pulmonologist, and I'm the president of Thai Asthma Council. I think the barrier, as other speaker said, the price is the most important. So in Thailand, basically, biologics covered in some population, but not all. population, not all the patients. Another barrier is the recognition of the government. I think in terms of burden, so basically the disease, whether it's asthma or it's COPD, is under-recognized in terms of the healthcare policy. So basically we as a doctor in Thailand, we under-diagnose this kind of disease. So when it brought up to the government level, then the government see this disease less burden compared to other disease, for example, cancer or diabetes. So basically the government itself so see this less burden. So basically in terms of supporting or making the policy to support the treatment is less compared to other. I think this is a big barrier in Thailand. We are kind of as a pulmonologist, we tend to be a little bit more conservative. As you can see in the many guidelines, we are still looking at the exacerbation. You know, in other disease, it's already looking at the molecular level, not the clinical level. So I think this is a big problem in Thailand, that the government, we diagnose less, then the government see this is less problem, and then hence the treatment is less support.
May I add a bit? Yes, I think in Malaysia as well we have that issue because let's go towards the insurance policy in our centers, in our country. It does not really identify asthma as a disease by itself, but it identifies as a congenital disease. So it's very difficult for you to actually get reimbursement in the private personal insurance one. Second is that in the government, yes, it's like Prof. Titiwat was saying, the government has not really focused and they're looking into lung cancers and so on. So right now, with our Ministry of Health, we are really focusing on the lung health initiative, and our head of service, Dr. Marzuki, is also focusing on that. We are trying our best to actually lay out and trying to make our government understand that this is the fundamentals, even to the primary care level, that you need to actually identify this and try to get really good access to really good treatments, as to simple as ICS LABA in primary care, and we are hoping that this would be just